Welcome to Driven, the Unscripted Success podcast, with your hosts, Mike Menino and Nariman Hamden, bringing you insights and stories on achieving personal, professional, and financial success.
Hi, everybody. It's Michael Menino, and welcome to Driven, Unscripted Success podcast. Today on the podcast, we're interviewing professionals who share their experience with you, the audience, and how they got to where they're at today. And zooming from the beautiful island of Tampa Bay, Florida, we have Melissa Smith. How you doing, young lady?
Oh, thank you so much. I'm doing well. And thank you so much for having me on today.
Oh, it is a real pleasure. Thank you for being on. Appreciate it. We were talking off camera, and the list of things you do and a mother is kind of exciting. Could you do me a favor and go through where you're at today and how you got there?
Yes.
And about the book. Don't forget about the book, best-selling book.
I will talk about Expanding Your Brilliance. That was a passion project that I did last year with 13 other women throughout the country, where we basically gave a compilation of where we are today as entrepreneurs, mothers, and just women in the space. And it was really a beautiful experience to be a part of that. But to give you some background on where I started in the pharmacy space. So I am a pharmacist. I'm a PharmD. I began in pharmacy as a technician with CVS Pharmacy before I went to pharmacy school. And once graduated in 2016 out of Regis University in Colorado, I started working again for CVS Pharmacy as a pharmacy manager. Went back into Florida, where I'm now rooted with my family, and was in pharmacy management for some time. Roll back to COVID times in early 2020, when the pandemic broke across the world. Things became a lot different in that space. And
how so? What were the differences?
So, one, we've always been the first point of contact for a patient to have access to a healthcare professional. That never changed, but what we were doing for them did change. So instead of me just filling medications and providing vaccinations, that was always part of the protocol as well for what we did as pharmacists in the retail setting. We now were doing COVID testing that was being rolled out on a massive scale. Not to mention, it was just a very uncertain time where nobody really knew what was to become of COVID and what it was going to have an impact within your own family, right? And I was a new mom. My son was maybe a year old at the time when this was all occurring, and I was scared to death. So it was just one of those times where expectations from a corporate level were, squishing down upon me, not to mention my ability to really bring forth a difference in the world. I felt with my knowledge base was really being smothered by just metrics and vaccination and testing goals, right? So I wanted to do something that really had more of a punch, impact, use more of my clinical brain. Not to mention, it was just a time where mentally I was not doing well. I had postpartum depression still, but also at that point with the pandemic and everything, it was combined anxiety and craziness happening in the world simultaneously.
Hyper pressure from everywhere.
Yes, it was a lot to deal with. And before I had a baby, it was different. I was like a machine. That never bothered me, working these long hours, 14 to 16-hour shifts on my feet, 4 to 5 days a week in the pharmacy. And then once you become a mom and you become a parent in general, this is for men too, your whole priorities and perspective shifts. It's a whole new sense of worry all the time.
Well, your perspective shifts from you to them. You're more concerned about yourself until that day.
Oh, yes. And separating from my little guy shortly after I had him to going back to work full time was a huge shift for me as well. I never fully adjusted. I suppressed a lot of it for a long time because I was working for over a year still in the space, even after I had him. But when that came, it broke me. And I knew that I was ready to not necessarily put down my pharmacist career by any means, but I wanted to change how I was utilizing it. And I was introduced to a colleague and friend of mine through a mentor who's also a colleague and friend of mine. So Jackie Boyle was the mentor. Jamie Wilkie was my spark to entering into the space of pharmacogenomics, PGX testing. And I had never looked back. So in 2021 is when I officially opened Florida PGX Consulting, which is my private practice, where I help patients with getting tested for their genetics and how they respond to their medications, prescription medications, before they take them. So it allows us to get more precise insight to how you may respond to therapies before you even take them. It helps to prevent adverse drug reactions, trial and error for patients, and just really making it more of an experience where it helps a patient to self-advocate for themselves when they're going into a doctor's office, being armed with an arsenal of information and personal awareness around what may be more appropriate for them, one, but also working with the doctors to make sure that they understand the information. So being an advocate for them, me, so that way, because here's the thing is, our doctors are, phenomenal in what they do. They diagnose, they can figure out what's going on, but then they're prescribing to us blindly. They don't know what's going to happen to us once they send us out the door. This is where the pharmacist comes into play. And this is where the relationship of the genetics really has a profound impact on how your patient's going to respond and ultimately thrive. So I make sure that when I have these interactions, even with the providers, that they feel empowered with me and not like I'm trying to make them feel unknowledgeable. I want them to feel capable with using it, if that makes sense. Because many times in my career, since I've gone on this journey of precision medicine, there's been many interactions where providers are very apprehensive to its use and its utility. And it's because there's a lot of God complex type physicians out there that don't want to necessarily take insight from somebody who has, the expert medication knowledge, let's just say. So
well, I like to say they're stuck on stupid, but I think you're doing it a little bit nicer than I would say it. Like,
well,
they have the rules and systems and process they've been using for decades, but they don't want to change to try to do better. It's just kind of amazing to me. Isn't it a fair, accurate description, or a little bit off?
I don't think that's fair and accurate because I think it's a time constraint for them. I also think that it's unfair for them to have that expectation placed upon them because I've had years of education around medications and pathophysiology, the pharmacokinetics, all the things. They had 6 weeks of this in medical school. So they have knowledge nonetheless, but it's a very basic knowledge. And where their expertise lies is interpreting your lab values, looking at the symptoms, and diagnosing your condition. A pharmacist can then looks at that, and then we can get a better read on what's to happen when we're combining all these medications together, saving you in instances where the combinations could kill you, right? I mean, they don't do this. This is what our job is for. And that's kind of where the disconnect from prescribing, I think, that pharmacists need to be included in on, because we're really more of the drug experts at the time of implementation. But physicians, nurse practitioners, their role is huge, and not to downplay anything that they do, because we absolutely need physicians who have the tactical work of I love
doctors, but I'm talking more like the hospitals and the places they work and the systems and process they work under.
Correct. Yeah. Forgive me. What exactly was the question again? I got lost.
So really, it's just the real question is the differential of what their systems and process is and what you're doing and how you help out. I'm assuming you help out more so than what they're doing.
So here's where I say that pharmacogenomic testing should be implemented in, that it's not currently as a standard of practice, is with it, when you have a metabolic panel, when you get your blood drawn, that's a quicker process. So genetic testing takes a little bit longer, anywhere from 7 to 14 days for a turnaround time. Or if you have an on-site lab, which a lot of hospital systems do, even for genetic testing, maybe 3 or 4 days, something like that. However, testing for this genetic information ahead of even prescribing the first medication should be what's now implemented. So that way the provider has that insight already within their EHR system to reference to for more appropriate drug selection. Let's give you an example. Let's say you've had a stroke or a heart attack and your doctor wants to prescribe you Plavix, okay? If you can't activate that drug, you're essentially taking like a placebo to protect you from another stroke and heart attack as part of a protocol. Plavix is a very common medication prescribed. It's one of the first line treatments that go into protocol, one for cost and one for clinical studies around it. But if they didn't have a pharmacogenomic test to know ahead of time that they can't activate it, they would have been put on a more appropriate therapy like Effient or Brilinta to start. So we wouldn't have to have this situation.
Trial and error situation.
Yes, it would significantly reduce drug costs from a overprescribing of inappropriate treatments. One, also adverse drug events for patients being hospitalized as a result of inappropriate medications, toxicities, drug combinations, whatever. And it's not that common practice yet. It's being implemented more and more. We're seeing it more readily available in geriatric populations because Medicare is commonly covering the cost of this genetic testing. That's also another barrier to these things where commercial insurance is for younger folks like in our age range where we just want to have this information for our lifetime. We're having to pay out of pocket for something like this. Mind you, it's not something astronomical anymore, not thousands of dollars. It's maybe in the neighborhood of like a couple $100. So it's for it being a once in a lifetime test to spend that on your health and drug selection potential. It's not out of the scope of somebody wanting to spend on, right? It's invaluable.
Gotcha. I see exactly what you're talking about. So what do you think the best possible outcome for people that take the test is to, I'm in martial arts and I say these words probably every week. Songs through the art of war. Know your enemies, you know yourself. You need not fear 100 battles. The biggest thing I've noticed on that saying is nobody really thinks about themselves. They think about the other person. So knowing yourself and the drugs that you take, which is becoming big now. A lot of people are learning. I bet you're getting a lot of patients that are learning information that's kind of wild to you when you come into some of the meetings.
Definitely. I spend a lot of time having conversations a lot about mental health medications, particularly because that is one where a lot of the high clinical evidence for pharmacogenomics is, but also where people struggle the most with finding the right medication. And in the very nature of how these medications work and behave and how you have to tolerate them, it takes anywhere from 4 to 8 weeks to finally get to kind of like even keel on these things before you have to go through certain amount of side effects. And that all can be related to how the genetics are playing a role and how you're responding to these therapies. They could either do one of two things. It can make them where you're at higher level for side effects or toxicities, or you could be less effective treatments because you're rapidly eliminating them out of your body before you even have any clinical benefit of taking it. So it can have opposite spectrum of impact, but knowing this ahead of time can save so much time and make people feel better sooner when we have this upfront. Not to mention, we can also look at how your body's behaving at a more innate level genetically as well with producing your own neurotransmitters to help support the antidepressants to work better. So there's a lot of insight that can be gathered from this one simple test to relate to why you've been experiencing so many things in your lifetime and having some validation to that, because so many times patients will talk to their providers about their experience on certain therapies and they get shut down as like a drug seeker. Great example is the pain management space. So there are certain opioids that have to be activated to give you pain control. And when a patient is telling the doctor, I'm still like you're taking a Vicodin, and they're asking for more because literally they're throwing up in front of you and they have no pain control. The doctors are just, let's give them more. Let's see what happens. when really they should be on a more appropriate opioid to begin with. Because the idea behind the pain management with the opioids is to be on the lowest dose of the most effective opioid for the least amount of time. And that prevents, one, addiction, two, better pain management and healing processes for those who need to take it. So yeah, I mean, there's so much nuance to it that it can translate into different areas of practice all over the place within just your health.
So let's talk a little bit about you talked about the antidepressant. I heard a crazy fact and see if what you do would help that out. So I heard that in the last 50 years, all the school shootings, the one commonality is they were all on depression medication, with the side effect would be
Suicidal ideation.
Suicidal ideation.
Mm-hmm.
And so they're not everybody that takes it doesn't have that side effect, but could your test show people that, hey, you would be more in this category than most people?
What it could show is that the therapy that they're currently taking, the provider may not know that they are slower metabolizers of that drug, and it could be lingering in the body longer, creating an increased risk factor for these intense side effects to occur, for sure. Not to mention with kids, especially with these young school shooters, it's more important than ever to have this insight prior to them starting anything, because most of these kids don't have any experience with medications at all. Not to mention their brains are still developing at this point. Their prefrontal cortex, where the primary point of contact for these antidepressants are working, may not align there as well. So having that insight ahead of time allows for proper dosage, drug selection in general, instead of just going off a protocol, right? There's, this patient was tested in this dosage, and I would assume that this person's going to respond the same way, and that's just not the case. And that's what I try to explain to doctors too, is that your patient may not need to be on the highest maintenance dose that's seen clinically, because they may metabolize it differently, where they function better at a much lower dose, or they may need a more aggressive dose to get therapeutic. It's my objective. Say that again.
Well, it's an interesting question, and I relate this to myself. So I try to hurt myself. I practice martial arts, so I get hurt a lot. And so pain medication is useful in certain attributes. And it seems to me that whenever I take it, it's really weird. Like, some of them don't work at all.
Mm-hmm.
Like, don't work at all.
Mm-hmm.
And then there's some that a little bit will do a lot for me.
Right. And are you speaking in the arena of opioids for pain management? Are we looking at NSAIDs like ibuprofen or Tylenol? Like what are...
Great question.
Yeah.
And I'm not a pharmacist. Let me just put this to the point where I know one that I like that works relatively well for all the pain that I'm, because there's different kinds of pain. There's bone, there's muscles, there's tendons, there's headaches, there's all kinds of different pain, right?
Mm-hmm.
It appears to me that the over the counters, the aspirins, it just doesn't work for me. Just plain out doesn't work for me. It doesn't reduce any pain. It doesn't reduce any it might reduce inflammation. It just doesn't work for me. And then when I try and get, like, I think the one that I like is tramadol. And I don't know what that is. Is that an opiate or?
It is. It's kind of what they would call the lesser of the evils of the opioids. It's not as intense.
That makes me feel better.
So what that tells me is that you likely don't have a problem with activating the opioids that are in question here, because tramadol is one of them. You have to activate it for it to work properly. So that lets me know that your CYP2D6 is likely either normal or maybe slightly rapid activity. We would have to know with the test, right?
Right. There you go. You got me into the test now.
But that infers to me that since you're getting pain control from an opioid, that has a lot of literature surrounding the CYP2D6 activity when it comes to understanding if you're going to get proper pain control, that tells me that you likely are a normal metabolizer with CYP2D6, which is a good one, because CYP2D6 is, in my world, one of the most problem-filled gene variants to have, because it impacts a lot of different medication categories.
What about I'm going to mess this one up. I have the MFRT, the Gary Brecka.
Yes, MTHFR.
What is it called? MATHR, yeah.
Yes, MTHFR, yes.
MTHFR, thank you. What is, they kept telling me something about folic acid.
Yeah,
and
I'll
it
talk
didn't
to you.
seem to work for me.
I'll tell you why.
Okay.
So with what they test for MTHFR is to see if you have reduced function with that enzyme. And MTHFR is important for one particular function in the body, and that's to activate our folate, our B9 vitamin. And
Okay.
folic acid is actually a synthetic made form of B9. Okay. It's
Right.
fortified into all of our foods currently, like into breads, to rice, to pastas, whatever. And
45% have this gene mutation of
yes,
the population.
about 40% of the population carries this gene mutation where they can't even utilize this vitamin that they're fortifying into our foods. So when we know this helps us to understand with people with lifelong depression and anxiety, because the activation of that folate is important because it allows us to then make our neurotransmitters in our body. So serotonin, norepinephrine, and dopamine. And what I talk about a lot with my mental health patients is when I see this on their testing, I ask them very specific questions. I say, have you tried a lot of antidepressants in your life and have they worked? And many times their response is yes and no, they haven't. And the reason for that is when we have an under functioning MTHFR, we then have a low abundance of those available neurotransmitters naturally in our body. And the way our antidepressants work is they have to have those in order to, because literally an antidepressant, all it does is it keeps those neurotransmitters in the brain area longer so they have more time to bind to the receptors to improve our mood. And when we don't have them, we have really poor response with them. So that's where a lot of the trial and error comes between patients trying antidepressant after antidepressant when it's a true root cause more at another gene level that we need to be focusing on and supplementing you for. So that's when they talk about supplementing with the activated form of B9. So L-methylfolate. It's a very common, add-on therapy when we see MTHFR variations for patients. But there's different levels of it. So you can be heterozygous for MTHFR mutations, which slightly
English.
yes,
For our
English.
viewers.
Okay, let's think about this. So when you inherit a mutation, you get one from mom and dad. So when you
Right.
have one mutation inherited, that means that you're heterozygous for a mutation, okay? When you inherit two, then you're homozygous. That means you're fully expressive for lower functioning enzyme activities a lot of times, okay? And with MTHFR, that's important for relativity of how much of an impact it has for you. Because let's say you only inherit the one mutation and only reduces activity of certain MTHFR enzymes to maybe 60% out of 100. When you're fully expressive for it, it can go down as low as 30%. So that's when we see an increased risk factor for this really being presented in patients with depression symptoms lifelong.
Wow. Okay, well that makes perfect sense.
I hope so. I tend to go a little high level.
It's a little bit hard to follow, but I understand most of it. And
yeah. Simplified here. If you're testing for this MTHFR variation and you've had lifelong depression and anxiety symptoms that has been unmanaged with antidepressant use, it likely will link to this variation for you because
really?
Yeah, it likely does because it's your body's natural pathway to create one of your natural pathways to create your neurotransmitters. And when that's low functioning, that's going to be inherently a overshadowing kind of a vibe for you your whole life. And many times when I have these conversations with patients, they're like, holy crap, like, did you know me? Have you looked at something else before you even looked at this genetic information? Because you're reading me to a T right now. So it's almost like I'm reading their tea leaves in front of them. And they just have this awareness, this awakening, this validation of what they've experienced their whole life and a reason for it.
Nice. I've heard those kind of sayings before or heard those kind of words before from people that have taken the test you're talking about. Now, your test is a little bit different than others. You do the whole spectrum. Or we talked about, I took a small test and it was just for four or five things.
Yeah, probably MTHFR was on there and other variations of MTH, I believe, is one of the other variations.
Correct.
COMT activity as well. That looks into dopamine breakdown in the body too. Yeah, the smaller panels are more looking at what's known as, for me in my world, pharmacodynamic genes. I look into the liver enzyme activity more deeply to get that understanding at the prescription medication level. So
Gotcha.
Primarily, whenever I'm evaluating for a tolerance and an expected outcome for a patient when they take a medicine, it's one they're taking by mouth that has to go through what's called first pass metabolism. So you have to absorb it in your gut, then it goes to the liver, and then it starts to do its magic, right? Or be eliminated, etc. So for me, it goes a little bit deeper past those other genes that we were just talking about.
Nice. So give me a quick overcoming story of something that happened in your career that you overcame.
Oh, failure. I can talk to you about a
Everybody
failure.
everybody gets it. Got to file down to the one that's, we're
Yes.
only going to do one today.
So what I learned in my space is that pharmacogenomics can be volatile depending upon the area of practice and focus you go into. And I quickly lateraled into partnering with the laboratories that test for these genes. So I provide the clinical counseling to the providers who are ordering, as well as the patients who get the results back, so they have an understanding and awareness around them. But I also have worked in executive levels with a laboratory that was in St. Petersburg from 2022 to 2023. And unfortunately, this lab was taken out by a cyber attack on the insurance processor that was utilized by a lot of different health systems, laboratories across the country, shut down a lot of different businesses because of this. So what I learned is that it's a volatile space. So you have to be very choosy where you kind of go into in terms of like a W-2 role instead of like a 1099 role. Like I prefer that now. So I would say that being very particular, sometimes you got to take a chance, and I don't regret it, because the people that I worked with and that I learned from there, it opened my eyes in an awareness in the space that it's a needed space, because it allowed me to work a lot more in the long-term care space. So I was in the skilled nursing facilities and assisted living facilities, testing the most needy population that's on multiple drugs. 15 or more medications on average is what we see in this
15, and we do investments, and we invest in the elderly care facilities. 15 is the average?
Yes, it's an average. And that's including over-the-counter daily supplementations, as well as over-the-counter just medications like Benadryl and like Prilosec. And then there are normal heart medications for cholesterol, for blood pressure, for heart arrhythmias, for dementia, for all the things. Yes.
Wow.
And that was a big initiative that was taken by this laboratory that I was with to basically drive down the risk of polypharmacy in these facilities by providing the pharmacogenomic information that allowed for more reasoning to these providers to, one, eliminate off medications, switch to alternatives that would be better, that would require less medications that were maybe causing side effects that they were treating with another drug, just adding it on, right? That tends to be what happens, unfortunately, because when they're elderly and we're trying to keep them comfortable, keep everything, keep them, in a steady point in their final days. And our objective as the pharmacist in that role is really to get them on the least amount of medications that keep them that way. So the pharmacogenomics helps with that.
I heard another crazy stat. I guess I'm a wealth of knowledge for crazy stats.
It's okay.
90% of medications can be taken away. So a doctor told me this. 90% of medication can be taken away from diet and exercise in the United States.
Certainly. Yes, I agree with that.
Why am I the only one that thinks that's a crazy stat?
Because a lot of it is all metabolic instability, and a lot of it hones in and originates from insulin resistance for patients, where it's a chronic crap diet of just processed foods, carbohydrates that constantly triggers the body to produce insulin. And when they are producing the insulin, then it becomes so used to this introduction, it becomes resistant to the introduction of sugar into the body. And this is where it then starts, instead of being utilized for energy, it starts getting stored as fat, visceral fat that sits around the organs. And that's when we get, the large midsections on people. This is when your A1C goes out of control. You get into type 2 diabetes mode, and then we're starting to manage that. All triggering into your cardiovascular disease, because that aligns also many times with the types of fats that we're taking in. So we're getting high cholesterol, high blood pressure, all adding a pill onto these things. And yes, diet and exercise.
Up to the average of 15. And then I heard another one too, that someone said that there's a phenomena that when people are at the last stage of their life, doctors generally, we'll say hospice area, that they take away all their medications. It's not necessary anymore, right?
Yes, that's very common. Yes, especially with just keeping them comfortable for end of days.
Right. And then sometimes when they take them off the medication, all their problems go away.
Then they all of a sudden have like a bounce back. Yeah.
The bounce back. That's the word I was looking for. Thank you. That happens?
It can, but chronically, when you're managed on a lot of these things for years, we're kind of putting a Band-Aid on the symptom, like the high blood pressure, like those things. And that's when the conversation of statins comes into play. When is it appropriate to discontinue a statin, especially somebody who's, maybe 100 pounds soaking wet and they have no fat on their body and they likely don't have high cholesterol anymore. And they have dementia. So that's
But they think they still have high cholesterol.
Yeah. And they do it because it's liability. And if they take them off and then they have some type of cardiac event, then it comes back to them, point at the physician who took them off the statin that was saving their life. But really the statistic around how it lowers your chance of a cardiovascular event is something very low. I think it's something like not even like a 1% decrease or something in your risk factor for it. I could be completely wrong, so don't quote me on that. But it's something along those lines.
Something nominal, very nominal.
Very, very nominal in terms of the scope of how it's actually keeping you from having another cardiovascular event. So there's more studies coming out against like the types of cholesterol particles that really cause the plaque buildup and what should be targeted versus what is already being utilized. Because there's more studies coming out where the reduction in cholesterol significantly for long periods of time is showing to increase the likelihood of dementia and Alzheimer's in patients. Because when we think about what our brain's made of and what it's swimming in, it's cholesterol. So if you're breaking that down in abundance for long periods of time, trying to protect against stroke, all the things we're trying to be proactive for in prevention, but unbeknownst to us, after years and years of utilization of it, it could be causing the things that we are more in fear of just forgetting everybody around us. So,
there's a higher risk. There's higher numbers in Alzheimer's now than there ever has been.
Well, think about the amount of statins and when they were introduced.
Right, exactly. Yeah, listen, this has been awesome. Last question for you. So it sounds like things are going pretty well for you now. Wondering if you ever created passive income and ways to do that.
Yes, I do. I in my practice, we typically go towards the route of a more, in a sense, functional type of a lifestyle where we're not necessarily biohacking, but we are optimizing the supplementation for patients. And within my practice, I utilize a company called Unscripted that allows me to help prescribe and align patients with the right types of supplements for them. And that allows for me to also have some type of, reimbursement back to me for supplementation that I'm referring to within that. But they're all like pure encapsulation, thorn, like very high level grade types of supplements that we want our patients to use and actually get some clinical benefit from. And other passive income, I do all sorts of different like social media presence for the laboratories that I partner with. I bring education that way. So I'm constantly educating and that's also a form of passive income for me as well. I'm thinking out loud here and, there's a few, but not a ton, but a few. You have to be able to think on your feet when it comes to those things.
You do. I heard this one saying, and I forgot who said it. I got to remember who said, if you're not creating passive income, you're going to work for the rest of your life.
True. So you're thinking more high level scope of like, not just like, so like maybe more like real estate, those types of things.
Well, we do real estate, we do multifamily, and it's a great way to create passive income with consistent cash flow, and it works great. I'm looking for other ideas. What I'm trying to do is find something to beat at night.
Yeah.
I can't find anything. I mean, real estate's a tangible asset. It's there. It's going to be there for our lifetime.
Mm-hmm.
And it consistently grows in value. So it's really, and plus these huge tax benefits. It's tough to beat, but I would love to see something that could beat it. But I like what you're doing. You're doing a great job of it. Hey, Melissa, thanks a lot for being on the show. Really do appreciate it. Wondering if anybody wanted to get in contact with you, how would they do it? Where would they go?
The easiest way is just to go directly to my website at www.floridapgxconsulting.com. Also, late in the game, kind of a plug here as well. I also am a part and co-contributor to a book called Expanding Your Brilliance. I am a co-author with 13 other women entrepreneurs within this book that basically go through our life experience and how we've gotten to where we are today as entrepreneurs and juggling all of those things as mom and women in the space.
Awesome. You're doing it exceptionally well. Do appreciate your time today. And please, if anybody wants to get in touch with them, get the pharmacological test. Did I say that right? What is the test? That's a mouthful.
I know it's pharmacogenomics, but you can shorten it to
pharmacogenomics.
Just say PGX testing.
PGX testing. Let's go with PGX testing. If you'd like to meet with Melissa, please get in contact with her. I think I'm going to hit her up after this podcast. For everybody else, thanks for listening. Appreciate you and your time. Don't forget to like and subscribe and hit the notification button. We do appreciate you listening to us, and it helps out the channel, and we'll get you more content as we come in. Thank you very much for being on, Melissa.
Oh, thank you so much for having me.
Bye-bye.
Thanks for listening to Driven, the Unscripted Success Podcast. Want to share your story? Apply to be a guest at drivensuccesspodcast.com/guest.